Well, good afternoon, everyone, and
Gracie.
Thank you so much for attending our health talk. My name is Philip Sines. I'm the Director and Administrator for Guadalupe Regional Hospice. My alternate administrator is Carmen Anderson.
Hi.
She's a licensed social worker and been with us for some time. Today we got two topics to really hit is this generalized of hospice care and when is it that time for hospice. As talked about, primary goals for hospice is to provide comfort, relieve physical, emotional, spiritual suffering, promote the dignity of terminally ill person. What is hospice? We both have different versions of what is hospice. Carmen has a really way of describing it, so I'll let Carmen elaborate a little further on what is hospice care.
So first of all, when we say what is hospice, hospice really is designed to help a person who's been diagnosed with an illness that a doctor has guesstimated that they have 6 months or less to live. Okay. Sometimes we see that our patients live past that number and they still get our services. They don't have to come off service because they've outlived the estimation. Okay. But it is not just for a person who's older and they're just, going through the natural life process of slowing down and declining. There has to be an actual terminal illness attached to that person. Okay. So from there, a doctor will oversee the patient, your loved one, with medications. And our main goal is really to keep your loved one from having pain. Sometimes we recognize that pain in the very first slide, it could be emotional, it could be spiritual. It's not necessarily physical pain, but sometimes pain can be pain related to the disease and the process of it. So our goal is to manage those symptoms wherever that person is at. So hospice is wherever your loved one is, whether that's in a home, a nursing home. Sometimes they're in the hospital. Sometimes they're in a personal care home. So we try to, wherever that loved one is where we're going to take care of them. It could be a nursing home, a group home, personal care home, inpatient at the hospital when their symptoms can be managed at home. So we have nurses that are part of the team. We have aides that are part of the team, social workers, chaplains, and a medical director who oversees, the medical director is the doctor who oversees all the pain and the management of the symptoms with the medication, but also is constantly in contact with the nurses about any changes that the patient is going through to monitor that. And then we have our director who oversees everything.
I like to explain it as that, that holistic team approach. It's a team, as she just explained, who specializes in the last phases of our life to prepare us for that next journey, wherever we may go in that journey. But it's a specialized team, just like you have a trained physician in the emergency room or in the OR who specialize in those fields. You have specialized OR nurses. Well, now for this last 6 months of your journey, or for whatever time it is, you have a team who is experienced in this preparation for that time, right? And so that's what I like to explain to my families and patients of what is hospice care. It's a team approach. It's a team to prepare us for that next phase of life.
I also like to add that a lot of times when we meet families, they're finding that it's harder to take their loved one to the doctor. They're getting sicker more frequently, and so they have to wait at the ER or the doctor's office, and that's taxing on a person. So think of it as everything is switched over to where the medical team comes to you, the person who's dealing with their illness. And then we look at the whole patient, the whole family as the patient, because we know that the patient's families are the caregivers most of the time. Or if they're in a nursing home, we look at the whole dynamic of that situation, because we're working together to take care of that loved one. Okay? And the last part of that team I didn't mention was volunteers. We also have volunteers that can visit with patients, sit with patients, offer that companionship, because a lot of times they just want someone there. And sometimes it's not even about talking necessarily, it's just having the presence of someone there. Okay?
When we talk about eligibility, I'm going to go over a few scenarios so that we make it more realistic to what we see. So our top diagnosis of what it's eligible for hospice is Alzheimer's, right? That's kind of the number one in a lot. So that is kind of the main one. And a lot of times some of our physicians will, you guys will go into the physician primary care, and we'll talk, and you might be there, you may not. That's when they'll consult us. I'll send a nurse out, reviews everything, assesses the patient, and then at that point discusses with the physician over the phone, and determines, okay, yes, they're ready for hospice at this point, and that's when they write that certification of illness, that they have the prognosis of 6 months. But that is a turning point, because they slowly lose that skill, that memory set that they used to feed themselves, now they don't. Now they need to be prompted. They used to bathe themselves, now they don't. And so all these things contribute to a time frame that physician makes. So that's kind of the number one diagnosis in a lot of hospices. Number two is cancer. So now we have cancer. We've treated it once. Those patients know what that's like. They go into remission, and now 5 years later it comes back. And at this point the patient's 5 years older, and you know what? I don't want to deal with that. I don't want to deal with that anymore. What are my options now? Can I, and hospice is at that time where, okay, now is the time to prepare us for whenever God decides, okay, well, this is it, next week or next month or next year, whatever time we have with our loved one. But hospice is a great team to have that support with that loved one if they decide not to go with treatment. The third and fourth is CHF and cardiac problems, and pulmonary and COPD. Those two are others. So our patient loved one went for stents. 5 years later, they went for an open heart, what we call a CABG, which is open heart coronary bypass, right? So now they're still having chest pain, still having heart problems, but no one would touch them because not only they're older, they're very high risk, but there's nothing more we can open up, right? So now it's like, okay, now the heart's getting weaker, now we're filling up with fluid, so what else can we do, right? And so that's when we see our patients. Now, I like to explain that when they come to us, cardiac patients, I like to say we have a trained physician on our team that knows how to manage these patients very well. So just because you come onto hospice doesn't mean that, okay, we're going to stop all cardiac meds and stop all, like the Lasix that is utilized for cardiac meds, but we continue the cardiac meds and the Lasix and any other diuretic that is needed so that they have the best life for the remaining time that they have. And that's very different from us and a lot of other hospices, is that they'll just stop a few things to make them comfortable, right? And that's not our goal. Our goal is to make sure our patient is going to live those last time frame as best he can, right? So that's the eligibility piece. After COPD, cardiac is kidney disease. So now we have kidney disease, they don't want dialysis, or they're tired of dialysis, and now it's time to talk, what else is out there if I don't want to do this, okay? And those patients, all these patients as I described, is hospice. Hospice is a great resource that insurance, Medicare, Medicaid will pay 100% because they know the benefit of having your hospice team on board for that last bit of life that you have left. So we follow the next slide with, when is that time? As we talked about a little bit about that Alzheimer demented patient, the coronary and cardiac patient, these are some of the real signs that you might see. You might see either huge weight gain if they're into cardiac problems like CHF, or you may have a huge decline in weight. So they're slowly declining weight because they're not eating, they're not moving. Like Carmen explained, you'll have frequent emergency room visits. You'll have not only emergency rooms, now you're hospitalized twice in the last 4 months, let's say. And so now you're looking at, okay, quality, am I getting better? Have I already run out of every resource and treatment? Now every treatment we're doing is not working because we're coming back over and over again. So these are the things that we look at, say, you know what, maybe it is time for hospice.
So these are just kind of some, not warning signs, but just kind of, hey, have you noticed these kind of things? So when you see these kind of changes over a period of time, the physical changes, the weight loss or the weight gain because of the CHF, as Philip was talking about, the readmissions to hospitals because something's going on, maybe falls are starting to happen, less physical activity, sometimes sleeping more will also be an indicator, eating less, not being as interested in things as they used to be. So those kind of changes can kind of be a signal that maybe treatment is no longer what is needed and it's not helping. So now we're going to go to a different path. We're choosing the path to get that person comfortable wherever they are.
So once our patient meets our eligibility to come on board, then like Carmen said, we have the option of bringing hospice to your home, or if your loved one is at the nursing facility, then we can bring hospice to the nursing facility. Once at home, if we find that the symptoms become out of control and we're worsening, then we can put them in an acute setting like at the hospital to control their symptoms with the goal to get back home to continue his hospice care at home. This is our team, our medical director. We have Dr. Nolan, Dr. Flores, and we added a new one in the Floresville, Lavernia area, Dr. Courier. We have hospice volunteers, certified nurses aides, spiritual care chaplain, our nurses, and our social worker. Every patient determined on where we're at in the illness depends upon how many visits you'll get a week. But yes, our providers is like I said, our aides who go in to bathe once, twice a week. Once the patient declines, we go more often. Once that nurse sees that, she'll go more often, and those changes. Those social worker and chaplain will go once, twice a month. Our social worker usually helps, and our nurse, with helping you find the resources so that you can meet your goals for home. Our service areas are 6 counties all around Seguin that we serve. Again, who pays for hospice? Medicare pays 100%. That includes your equipment that your loved one may need: bed, oxygen, suction, bedside table, anything that you feel is needed, we will provide. So if they end up getting a wound and need wound care supplies, we will provide the wound care. If your loved one's on a tube feeding, as they were, before hospice, and they come on a hospice with the feedings, we will provide the nutrition that they're on for that. So what I've seen is that they have Medicare, they come on at home, they work on Medicaid, and then the patient becomes, how would you describe it? Very difficult just for one person to take care of. But now with Medicaid, they're looking at other options. And so at that point, they look at nursing facilities, because nursing facilities, Medicare will pay for the hospice portion, but Medicaid will pay for the room and board. And Medicaid will also pay for those providers that you look for several hours. They have several contracts with local companies that they can help with those providers. So those are other options down the road too. Right. But if patients don't have Medicare and all they have is Medicaid, we still take them, and Medicaid pays. And most insurances plans will pay for hospice, but a lot of the insurances like to dictate exactly what will be provided. So just the nurse for the first 30 days. If the patient feels like they need the aide or the social worker after 30 days, then however, we're very unique and different at Guadalupe Regional Hospice, where we give our whole team to that patient. And we don't really worry about what they're going to reimburse us, because we know the full benefit of having the whole team offered to all our patients. And so that's one of a huge difference between us and any other hospice that you would.
Can I also add, because when we say who, is that Medicare, Medicaid, private insurances, but also if a person is uninsured, they don't have insurance, we will still, if they meet the criteria, we'll still service them. They'll take care of them. Yeah, they don't have to have insurance.
We raise money every year, a special event that we have every year called Pistols and Petticoats, that we raise money just for that reason, as we take everybody that qualifies, insured or not. Again, this is kind of just a recap of what hospice includes. Talked about our team, medications. So talk about all the equipment, supplies, medications. We cover, I would say, probably 98% of all medications once you come onto hospice. Our nurse picks them up from our local pharmacist. We use Parker's and Mormons, and then we deliver them to you and review all the education with the medications. Inpatient care related to hospice diagnosis as well. So if loved one happened to be in the hospital, is too sick to be home at a nursing facility, then all hospices will do inpatient. We have a contract with the hospital, with GRMC, who our patients will be seen in inpatient there. And then, let's see, respite care is something we didn't talk about. Respite is once on hospice, if our families need a break, time off, then we will admit your loved one into our hospital for 5 days or a nursing facility for 5 days so that you can take a break. We can utilize that as often as you need. Okay? It's not a once per benefit period. We can go once a month if that's what you need and that's what's best for our patient. Some of the experiences we have with this, if our patients are becoming a little difficult at home and we're exploring the nursing facility route, they will do a respite stay at a nursing facility of their choice for 5 days. If y'all enjoyed that experience, then you guys can then talk and negotiate okay, maybe we take our loved one there in the future. Okay. Yes,
we have contracts with all of the nursing homes here in Seguin. Yes,
we even have contracts. We've had patients and families requesting a nursing facility in Swivolo, one in Gonzales, one in New Braunfels. So if you have more family in the New Braunfels area and they want your loved one there, then y'all negotiate, and that's where we can do that as well too. And then our bereavement support, you have Carmen and her team, our chaplain, that will be with you for the next 12 months after you have a very strong connection and relationship with our team so that you're not alone. We're glad that you're here because, without knowledge, without knowing what your resources, what's your options, without having this very difficult conversation, you wouldn't know. And that's why I'm sure there is no one other than you here, because everybody is fearful of this word hospice. And we're trying to send a strong message to the community that it is not scary. At some point we're going to have to talk about this. Why not talk about it now while we're not on his deathbed or her deathbed, and let's have these difficult conversations with professionals who know what they're doing. This was a statement. I'll let Carmen elaborate a little bit more.
We took care of Mr. Kaler, and his family was just very, very grateful for the support that was given to their dad in their home. And when we can make an impact with one family, I think we've done a good day. It's a good day for us. We walk that journey with the family. We help them because we do this every day, and they may not do this every day, right? And so a lot of times there's fear. They're afraid of saying goodbye, but we have to help them get prepared to meet that because it's going to happen. So let's try to do everything for our patient. And so we get very close with our families, and I think they feel the sincerity and really the genuineness. It's not a job for us. It's really an honor for us to be involved and to be chosen. There's lots of hospices families can go to, lots. But we're here, we're in town, we're close. We're a very good team. We all work very well together. There's always 2 nurses on call every night. So even if you had a question at 2 a.m. and something changed, with your dad's condition, you can always call and they talk with you. They figure, is this what you're doing? Have you tried this? I'll call you back in 10 minutes and see if it worked. Do you want me to come visit? The support is there. So I think that's the biggest piece piece that we're really trying to convey. Not only is when it's time for hospice, but what does that mean for you and your family? Like, how can we best serve you? And this is one way to educate our community. But, you know, I think it's time to normalize the word hospice, because I think a lot of people still are fearful of it. They're fearful of the medications, about morphine. Is my loved one going to get addicted? Is my loved one going to just be asleep the whole time? And yes, so there's possibilities of the sleeping, but not the addiction. But I look at it this way: if your loved one is restless, if they're uncomfortable, and we give them a little bit of medicine to help them relax, wouldn't you prefer that versus seeing them uncomfortable and just not being themselves? So there's a lot of things that we educate along the way, depending on what is going on with that person. It's very unique and individualized for that patient and that illness.